Hi everyone, we're going to start talking about the topics covered in chapter 1 of the textbook, which is titled What is Public Health? Some of this is going to be a little bit of review or expansion upon things that we did in our previous lecture, and some of it is going to be entirely new. So these are the main topics that are covered in the textbook, and so I'm going to structure today's lecture around that. So the ways that our lives are impacted by public health, a little bit about the history, and then I'm going to go out of order from how the book goes. So the book then goes on, kind of do we focus on high risk versus an everyone approach, and then talking about the different health risks over the course of a person's lifetime, and the different types of approaches that we can take in impacting health on a population level, as well as the determinants of health. We've talked a little bit about that previously, but we're going to expand on it today. And then changes in population over time. So that's the order the book goes in. I'm going to go a little bit out of order because it made more sense to me, but I don't think you'll have trouble keeping up. So when we think about all the ways that public health impacts our daily lives, they are innumerable. And so the textbook does a really great job talking about all the different components of a day in the life and different ways that our health is improved or our safety is improved because of public health measures that are in place. So just a quick sampling, there are more in the book and you can come up with more on your own. Right, so wearing seatbelts has done more to decrease fatalities from motor vehicle accidents than almost anything. So making laws requiring the use of seatbelts has had a huge impact on our overall health as a population. Drinking water, safe, clean, healthy drinking water is crucial to the health of a population. Nutrition labels. So I'm old enough to know that they didn't always used to exist. So the ability to know what's in our food and how healthy it is or isn't is actually a relatively recent phenomenon. Sewage. So the handling of human waste and excreta is actually exceptionally important in terms of our health and well-being. There are many, many diseases that can be spread through sewage and fecal matter. So the fact that we have flush toilets and sewage treatment systems to take care of them, or septic systems to take care of them, has had a huge impact on our health and well-being. This is a picture of people smoking in a restaurant. So I am also old enough to remember days when smoking was allowed in restaurants, which seems absolutely crazy to us now. How can you even enjoy the taste and smell of your food if all you're smelling is cigarette smoke? But in fact, that used to be widespread and common. So yet another way that public health has improved the health of our communities. And then this is a picture of a Chinese food buffet. And so public health agencies are also important in regulating restaurants and making sure that they maintain their foods that are supposed to be cold at the appropriate cold temperatures, and foods that are supposed to be hot are maintained at the appropriate hot temperatures, and that they have appropriate sanitation measures in place to make sure that when you go to a restaurant, it is actually exceedingly unlikely nowadays that you will ever get food poisoning, which if you've traveled to some other nations that don't have as rigorous a public health oversight of their restaurants, perhaps you've had experience with this firsthand. So many ways that public health impacts our daily lives for the better. So the next thing I'm going to touch on is the history of public health. This is one of my favorite topics, and I am trying to keep myself to a very short snippet of time here because I could do a whole course on this. I think it's fascinating. So there is some excellent material in the textbook, as well as some of your media assignments focus on some of the highlights, some of the important figures and features of the history of public health. But I just want to point out a few things. So quarantine and isolation have been in use for a really long time, right? So even in the Old Testament, they talk about, separating people who have disease and, the leper colonies. And so we've recognized for a long time, even before we knew what germs and bacteria were, that separating the sick from the well can help prevent spread of the disease to other people. Sanitation measures are huge. We think some of the earliest toilets actually were in the Indus civilization, which is in modern day Pakistan, several thousand years ago, as well as in the Minoan island of Crete. And then, of course, the Romans famously had a lot of public bathrooms and sanitation measures. Unfortunately, jolly old England in the 1800s really was not doing well in this way. And so you'll hear a lot about that as we talk about and watch some media about the birth of epidemiology. So looking at the cholera epidemic in London in the 1850s and how that really provided the impetus for the first study of disease at the population level rather than the individual level. And so when you watch the video about the ghost map and Dr. John Snow, who was kind of the father of epidemiology and looking for patterns of disease in a population to help identify the potential causes, contributors, and determinants so that then you could intervene and improve the health of a population. It's a great story, so I hope you enjoy it. Another important advance was the keeping of vital statistics, so birth records, death records, cause of death. It was not customary to keep track of those things in most societies. And in fact, if we look at kind of the history of European civilizations, usually just your local church kept a record of births and deaths, and that was it. And there was no centralized data collection. So now we know that we can use the power of data to identify trends and follow conditions and diseases in a population over time that can be really helpful. Vaccination, of course, was super huge. So Edward Jenner noticed that the milkmaids who often tended to the cows and often got infected with cowpox, right? So that was a zoonotic disease or a disease they caught from the animals, then seemed to have some protection against smallpox, which was a devastating disease that was often fatal in humans. And so he got the idea of inoculation. So he would purposefully give people small doses of smallpox, actually, in order to help them prevent them from getting severely ill if they were exposed to it again in the future. So that was pretty remarkable that people were willing to try that. And that happened even before we understood what germs were. So even before we understood how diseases, infectious diseases or communicable diseases, as they're often called, are actually transmitted, and that they're due to these little microbes or germs like bacteria and viruses. The ability to investigate causes of disease really took off after germ theory came to be, and we developed tools and technologies that allowed us to investigate things further. So our ability to do blood tests, our ability to look under a microscope to see things at those tiny, tiny levels, right? These hidden worlds that we'd never seen before. So in the past couple hundred years, our ability to investigate the causes of disease has really taken off. Social policies are huge at contributing to the well-being of a population. So things like having proper sanitation and of course proper airflow and air circulation and ventilation was shown to be really helpful at controlling tuberculosis outbreaks, for example, before they even knew about the bacteria that causes tuberculosis. But also things like education and food programs can be really helpful at improving the health of a population. Then, of course, there's access to health care. And so in the past century, our United States government passed Medicare and Medicaid to make sure that people who were elderly or impoverished had access to medical care. Different countries have come up with different systems to ensure that access. And then health promotion is kind of this idea of helping people to make healthier choices for their own individual health behaviors. So we have all of these things that have kind of transpired over the past thousands to hundreds of years that have improved our ability to positively impact health at the population or community level. So that's my brief spiel on the history of public health. Next thing I'm going to talk about is the impact of the life cycle on health and wellness. So we don't necessarily think about this objectively all that much, but depending on your age, you are at risk for lots of very different types of medical problems. So the types of health issues that we see in infants are very different from the types of health issues that we see in elderly people, for example. So I'm going to take you through the stages of the human life cycle and talk about some of the major causes of death and disability in those age groups. So death is pretty clear cut, right? So an end to your life. Disability is something that impacts the quality of your life or negatively impacts your ability to function in the world for a variety of reasons, okay? So let's take a look. So, I guess my little video square is over the very elderly. So I don't quite qualify as very elderly yet. But you can see on the bottom here kind of, our lifespan. And I've included in this slide the fetal period, right? So when we are inside our mother's wombs, we are vulnerable to particular diseases at that time. And then into the newborn or neonatal period, early childhood, middle childhood, adolescence, young adults. Working in middle adults, which you'll see is kind of the biggest bucket. So it spans a 40-year period of time right there. And then older adults and then very elderly would be the over 85 group. So if we take a look, in the fetal period, the predominant cause of death is genetic defects. So we're talking about miscarriages here, and it's almost always due to an error in the genetic code that is incompatible with life. Sometimes there are also injuries that occur to the fetus, either because the pregnant person has an infection or consumes a substance that is toxic to the fetus. But the vast majority of times it was a genetic anomaly. Just when sperm met egg, we didn't get quite the right lineup there. And so it's just a genetic code that's incompatible with life. So that's the fetal period. Once you're born and you're in that early infancy period, that neonatal period, it's still genetic defects are the largest contributors to death. But being born premature is also a huge risk to the life of an infant because they're not done developing yet. So they're not quite ready for prime time. They're not quite able to breathe on their own. They're not quite able to eat and digest and absorb nutrients on their own. And so prematurity is one of the leading causes of death in the very young. And it's SIDS, which is sudden infant death syndrome, which is a fascinating condition and probably represents multiple different medical conditions altogether, is one of the biggest causes of death in that early infancy period. When you move into toddlerhood, for the most part, then we're looking at infections. So even in the United States, where we have excellent vaccination campaigns, we have excellent access to healthcare for most but not all people, we have availability of antibiotics, infections still are a big cause of death in that age group, followed by injuries. So accidental injuries, car accidents, drownings, falls, those types of things. Now, there are not many of these deaths, so I didn't put in here, but the book has in the table kind of how often deaths occur in this age group, and they occur very rarely in this age group, but when they do occur, these are their causes. When you move into school-age children, and the younger school-age children, we're still seeing injuries, car accidents, drownings, those types of things as the major causes of death. But then we also start to see the childhood cancers. They tend to start usually around age 5 to 7 to 10. We start to see leukemias and some other unusual cancers. These are still very rare overall. People in this age group don't die very often, but when they do, it's usually from injuries and then cancer. And then once you get to age 10, we start to see suicide creeping up. So that becomes the number 3 cause of death in this age group. As we move into adolescence and young adulthood, which is where many of you are still, injuries are still really high, and we start to see homicide actually, so death by violence, it becomes a lot more common, obviously in certain communities more than others, and then suicide remains a leading cause of death in this age group. Again, death in this age group is really uncommon, but when it occurs, it's usually injuries, homicide, or suicide. In terms of disability now, we're starting to see the appearance of things that cause a decrease in function or well-being. And so in adolescents and young adults, by far, the major cause of disability is mental health disorders. So depression and anxiety by far lead the pack here. We also see some disability from things like ADHD or autism spectrum disorder that can cause difficulties for people in their life functioning. As we move into the working adult or middle adult population, again, on that younger end, we're still going to see injuries. So car accidents, car accidents, car accidents. And then now we're starting to see a lot of drug overdoses. So a lot of, especially in this country, deaths due to opioid overdose are skyrocketing. So that's a big problem, as you're aware. We also then, toward the end of this period, right, because this is this big, big bucket. So once we get kind of over age 50, now we're starting to see cancer and heart disease come onto the scene. They have, we had a blip of them in childhood, and then young adulthood, usually we don't see a lot of cancers, and then we don't usually see them in the 20s and 30s, and even in the 40s, and then once we get into our 50s and 60s, cancers really start cropping up again, as well as heart disease. In terms of disability, now we're also seeing musculoskeletal disorders. You might be like, well, what's that? Well, back pain is the big one. So we see a lot of back pain in this population, sometimes due to occupational injuries, right, due to their work, sometimes due to other types of injuries, and chronic pain and back pain become significant causes of disability in this group. We continue to see disability due to mental health disorders. That is a persistent challenge. As we move into older adults, now cancer and heart disease are going to predominate as the major causes of death. And in terms of disability, stroke, which is sometimes fatal, but in this age group often not, but can leave you with lots of deficits. And then Alzheimer's disease, which is the major cause of dementia in this country. So we're starting to see loss of function and wellness due to stroke and Alzheimer's disease in this population. And then once we get over age 85, heart disease and cancer are the major causes of death. Heart disease and cancer are the major causes of death, period. None of us are getting out of this world alive, right? Life is a terminal illness. Something has to kill you, and usually it's going to be that your heart fails or that you develop cancer. Them's the facts. In terms of the major cause of disability now, dementia is really the leading cause in that age group. So depending on what age you are, different health conditions or diseases are going to become more or less relevant. So that's going to be really important as we think about the health of a population and think about what are the issues that are going to be most important at that population level. So here is one of my favorite websites. I'll have you play around with it for one of your activities this unit. And so this is a website maintained by the University of Washington, and they have this incredible database of data about causes of death and disability, and lots of different ways that they produce these visualizations of it. So what we're looking at right here is you can see, let's see, I'm going to use my little highlighter, I think. So, oh, look over here, I have selected deaths in the United States of America for people under the age of 5, right? So that's kind of how I've set it up. And so what you can see, and I don't think you can see my arrow. All right, so we can see, whoops, hello, congenital causes, right? So those congenital defects are still common. Neonatal, these are things like prematurity, complications of prematurity. And then here is SIDS down here, that's sudden infant death syndrome. You can also see, foreign body, right? So this is choking, right, as a major cause of death in this age group. So that's in the under 5s. Now I'm going to switch and we're going to look at 5 to 14 and take a look at the changes. Wow, huge change, right? So once you get to age 5, look over here, road injuries, right? So motor vehicle accidents. All of, let's see, these over here are the cancers. We still have some congenital defects. and then we're starting to see suicide, right? So those are the major causes in this age group. Now you see their age groups are a little bit differently bracketed than the ones I talked about before. That's a problem that we're going to see actually in our country. There's no standard for what exact ages we group populations by. So depending on what organization's data you're looking at, it will be grouped differently. So if you're looking at the state of Wisconsin versus CDC, for example, they use different age ranges. It's really frustrating. Different countries, other countries don't have this problem, but we do. Okay, so let's move on. Ages 15 to 49, huge change again. So we're still seeing car accidents, we're still seeing suicide. Now, these are drug overdoses. So this is my age group for another 6 months. So these are the things that these folks are most at risk for. Then up here, all of these together are cancers. And then this right here is heart disease. Let's see, can I make a heart? No, not really. I'm not very talented. Okay, so we're starting to see those crop up now as the population ages. Let's move on. So ages 50 to 69. Now look, okay, here's heart disease. Oh, I forgot I was going to draw heart. So there's heart disease here. And then where is my, whoops, here it is. Over here, these are all the cancers, right? So those are going to be the major causes of death in people ages 50 to 69. And then they do 70 plus. So for 70 plus, in terms of causes of death, again, here's our heart disease. Here's stroke. That's supposed to be an S. And here is cancer, right? So these are going to be our big causes of death. And then down here is lung disease, a big L for that, lung disease from smoking. And then down here is Alzheimer's dementia, right? Which is going to be the prominent cause of death in the very elderly. So very different things to be concerned about health-wise, depending on the ages of the people in your population. So not only is it going to be different by age, but it's also going to be different based on where you are. So one of the things I really love about that website is you can look at different regions of the world. So as an example, here are the deaths, causes of death, ages 15 to 49 in the United States. And I'm going to show you the causes of death for the same age group in South Africa. Hugely different, hugely different. So this huge dark, let's see, right? This right here, that's HIV. So HIV is the major killer of working age adults in the country of South Africa by far. It far exceeds anything else. I don't even see drug overdoses on there, nor do I see heart disease, right? They still have self-harm, they still have suicide, they still have violence, they still have road injuries, but the vast percentage, the largest percentage of their deaths is caused by HIV. And so as we think about those determinants of disease that we talked about before, and we think about, well, what's different between South Africa and the United States? And so remember, one of the determinants that we talked about was biology, right? So we talked about kind of your genetics or your biology. So are the genetics or biology of people who live in South Africa very different from people who live in the United States? And it turns out no. So there's nothing biologically that makes them more vulnerable to HIV than people in the United States. We are genetically far, far, far more similar than we are different. And there's nothing about our genetic code that confers an advantage or disadvantage in terms of HIV. Now, what about health behaviors, right? So are health behaviors very different between the United States and South Africa? Well, in terms of number of unprotected sex partners, no, actually, they're not very different at all. Just as many people are having unprotected sex in the United States as are having unprotected sex in South Africa. There are a few differences in behavior in South Africa. It is more common to have several different partners at the same time. Rather, in Western countries, it's more common to have serial monogamy, where you'll be with somebody for a period of time and then with somebody else and then with somebody else. Whereas in South Africa, it's a little bit more common to have, a couple of sexual partners at the same time. So there's a little bit of difference in health behaviors. What about medical care? Is there a difference in access to medical care? A little bit. It's not huge. Actually, South Africa has a pretty well-developed medical and health system. There is a little bit of difficulty in access to some things, but for the most part, it's fairly equivalent to the United States. So we're left with that last chunk, right? That purple chunk, those social characteristics, the total ecology, the total environment in which you live. And one of the major differences why the HIV death rate is so high in South Africa is just because there's a lot of HIV around. So the likelihood that any partner you have has HIV and could infected you is about 100 times higher in South Africa than it is in the United States. They just have more of it around, so it's easier to catch, right? Which then perpetuates that cycle of there being more of it around, and so it's easier to catch. We also see differences in terms of education and culture around condom use and safer sex. So really, again, those purple things, those social and societal factors, that total ecology in which you live, is the major driver of this difference that we see in HIV infection rates and death rates between the United States and South Africa. Oh, I will say one thing that is very different, medical care wise, I forgot to bring it up, is access to HIV treatment. So medications to keep HIV in check and extend your lifespan once infected with HIV. We have much more access to that here in the United States. So that is also another powerful factor. All right, so things vary a lot from place to place because of all those factors, especially that big purple one. So the book talks about this at the end of the chapter, and I'm going to talk about it now because I think it makes more sense. So changes in populations over time. So because the ages of people in your population are really important, the numbers of people in any age group that you have over time can change, and that's going to have a big impact on your public health. So if we look at the United States currently, so this is what's called a population pyramid. And so what you can see down here at the bottom is ages 0 to 4. And then we have the percentage of the population. So this is, I don't know, what is that, a 4, I think? And same over here, right? Or no, 3. Okay. It's tiny. I'm old. Okay. So about, 3% of the US population is currently composed of males ages 0 to 4, and about 3% of the population is composed of females ages 0 to 4. And what you can see in the United States is that we have a pretty square population pyramid. Most people, live until we start seeing it falling off, around age 70, right? And so average life expectancy is somewhere in the 70s for most people in the United States, but it varies depending on a lot of factors. And so we can see that the population rate stays pretty similar until people get older and then they start dying off, right? So then we see fewer and fewer people as you get up to those upper ages. You can also see on this population pyramid that female-bodied people tend to live longer than male-bodied people. So you can see that that red bar is higher than the blue bar when we get into those advanced ages over age 80. Females significantly outnumber the males. So this is a population pyramid, and the next slide I'm going to show you is a GIF that's showing how that has changed over time. So that's what we're going to call demographic shifts, because demographics are kind of like the ages and genders of the people that make up your population, and those demographics shift over time. So we're going to take a look at that next, if I can make it work. Okay, so what we're looking at is this scrolling GIF looking at the United States population period over time. I've tried to pause this and failed. So this is my second attempt to record this slide. So I'm just going to talk you through it. So up at the top, you can see the year number is changing. So it's going to reset right now. there we go, to 1980. And then as that year goes up, everybody kind of ages up into the next age. So you can see on the, let's see if I can use my pen. So over here we have ages, right? So everybody starts off at 0 and then ages and eventually dies off, okay? And then these over here are the year in which you were born, right? So what we can see as it resets here in a minute is that the number of people in the United States was quite low. So that lost generation, greatest generation, silent generation. Now look at those baby boomers, okay? And so what we're going to do now is look at that baby boomer generation as they move through the ages, all right? We're going to look at that again on this next go around, right? And you can see, so there's a massive increase in people age 40, 50, 60s, right? And so right now, in the early 2020s, right, we have massive numbers of people, much higher numbers of people than we ever had before, who are in that older adult and elderly category. It used to be a very small percentage of the population. Now it's a pretty sizable percentage of the population. So after the baby boomers came Gen X, which is a slightly smaller generation, and then millennials, which is slightly larger again, and then Gen Z is kind of coming back down and is a little bit smaller again. So as different ages of populations move through their life cycle, there are going to be different conditions that are more common or more prevalent in our population as a whole. So right now, care for the elderly and the very elderly is taking a lot of our societal resources because there are a lot of those folks, whereas there didn't used to be. But as you look at the populations, you can see that there's going to continue to be a lot of people in that age group, probably for quite some time. All right. The other thing I want to point out with population pyramids is not only do they change over time, but they're different in different places. So sticking with South Africa as an example, because it has lots of interesting ways in which it's different from the United States. Again, there's our United States population pyramid on the left, and then on the right we see South Africa. And it should become immediately apparent to you that in South Africa, once you reach age 40, we see a huge decline in the numbers of people in the population. So in fact, 2/3 of people in South Africa are under age 40. So they do not have many older people at all. That has to do with changes in birth rates, that has to do with access to medical care, that has to do with the high mortality rate from HIV infection. Lots of different factors contribute to that. But what we see in South Africa is that they have a much younger population proportionally. And so that's been one of the reasons why extrapolating the data on Omicron, for example, the new variant of COVID that first was kind of discovered and described and first caused a big surge in South Africa, is complicated. So Omicron has not caused a ton of severe illness and death and hospitalization in South Africa, but we know that one of the major risk factors for severe illness, hospitalization, and death from any variant of COVID is older age. And they don't have many people who are of older age. So we would not expect South Africa to necessarily see a huge bump in hospitalizations and deaths from COVID-19. So extrapolating from their country to ours is a little bit difficult. Now, there are lots of other ways you can kind of control for this and figure it out, and we're still figuring it out right now. But so certainly the health concerns of their population as a nation are going to be very different from the concerns of our population. Another transition, aside from demographic transitions that occur, are nutritional transitions within populations. So what we're seeing on the left-hand side here is images of children that are not getting enough food to eat. So what we often see in developing nations is that there is a very high rate of famine or food insecurity or lack of access to appropriate nutrition. And so famine and starvation and malnutrition are the primary concerns of those populations because they have huge impacts on the health of the society, of course. And it's really easy sometimes to think, oh, this only happens, this is only starving children in Africa and other developing nations. But also keep in mind that we have lots of pockets of food insecurity and malnutrition even here in our own country. They are just smaller and less prominent than what you see in less developed or less wealthy nations. And then, of course, as a society becomes more developed, becomes more wealthy, then we see kind of the flip side problem. So there's just too much access to nutrition. We see overnutrition, we see obesity rates, and then the diseases that accompany obesity, so things like diabetes and heart disease, start to skyrocket in those populations. So as in many things, balance, right, is of the best. Moderation is best. You want enough good nutritious food and not too much. Okay, so we've been dancing around this already in this lecture, but let's talk about kind of how do we understand health and the factors that determine health. So we're going to talk a little bit more objectively and directly about that. So when we think of a disease, right, there are things that are called contributory causes. So things that are risk factors for you developing that disease, right? So certain people are at higher risk of developing cancer than other people. Some people are at higher risk of heart disease than other people. So those are the contributory causes, for example. But then there are determinants, which are kind of the causes of the causes. So what are the things that make it more likely that you will have the things that increase your risk for the disease? So I know that sounds kind of abstract, so let's give some examples. So if, for example, you don't get some comprehensive sex education because of where you live usually, or the type of household or culture or religion in which you are raised, statistically, and it can vary by individuals, of course, but statistically as a whole, those folks are more likely to engage in unsafe or unprotected sex, and therefore they are also more likely to develop HIV. So using that example, right, so unsafe sex is what leads someone to develop HIV, but there are things further upstream that make it more or less likely that they'll engage in unsafe sex. Another example. If you have a lot of people around you who smoke, friends, parents, that cool kid that you want to hang out with in the high school, then you are more likely to become a smoker, which means you are much more likely to develop lung disease from smoking, which is called COPD, right? So as much as we like to think that we are the own masters of our fates, we are actually very influenced by the people and the environment around us. So those are those determinants of health. So we talked before about kind of your genes or your biology, your individual health behaviors, your access to medical care, and then your kind of social determinants before. What the textbook does is kind of takes that and expands it even further into this big GEMS approach to the determinants of health, which I like actually quite a bit. And they map pretty well onto kind of the big four that we talked about previously. So I've color coded them so you can kind of see. So for big, B is for behavior, the individual behaviors you choose to engage in, right? So that's kind of the red one. I is infection. Now, interestingly, your likelihood of encountering an infection is mostly due to the ecology of the place where you are, right? So as we saw in South Africa, there's a lot of HIV around. You're much more likely to get infected. So I coded that one purple. Genetics, of course, your genes, your biology, your age, your sex, those things are definitely a piece. And then your geography. So where do you live? I live in Wisconsin. I'm not going to get malaria, right? And that's not because I'm using a bed net or something, or mosquito netting, or it's just because it's not here. I've already gotten Lyme disease, right? Because that's really common here. But for someone in Alabama, Lyme disease is not very common, right? So your geography is really important, not just in terms of your risk for certain infectious diseases, but also in terms of, I live in a place with really clean, clear air. I used to live in New York City. that was not the case there, right? So our geography has a huge impact. And then environment. So where geography ends and environment begins, I think is variable, but environment can mean anything from the quality of air that you breathe to the quality of the water that you drink and the infectious diseases that you may or may not come into contact with, but also, is your home well insulated and warm, right? Is there radon in your home? Is there lead in your drinking water, right? So that can be lots of different things. And then M, medical care. We've talked about that before. And then they have S, socioeconomic and cultural. So we know that people who have higher socioeconomic status in general tend to have better health status, in part because they have better access to resources, they're wealthier, they can afford nutritious foods and gym memberships and all those types of things. They're also educated and they know about what things can help protect their health. But then there are also cultural things, as we're actually even seeing in the United States right now. So, for example, people who tend to vote Republican are much less likely to be vaccinated against COVID. And people who vote very Republican as a group have a much higher rate of death from COVID because they are less likely to have been vaccinated. So cultural beliefs, and which usually they weren't political things that influenced your decisions on healthcare. Usually it was just things like religion and culture. But yeah, all these things can have a huge impact. So the book does a really nice job of talking about the example of Jennifer, a person with asthma, and looking at how this big GEMS approach, all these different determinants influence her health and her outcome from her disease. So make sure you read that. All right. So I just want to counter a little bit. As Americans, we tend to get inundated with a lot of kind of pull yourself up by the bootstraps, individualist messaging, because that's kind of the way our culture tends to go, right? So a lot of these things you probably see on the regular. So you're responsible for your own health. You're completely responsible. It's all in your own hands, right? Only you can choose to be healthy or be sick, right? At the end of the day, your health is your responsibility. And while it is true that the individual behaviors that you choose to engage in or not, to the extent to which you can consciously choose them, is important. And while it's true that you can influence your own health for the better by the choices that you make in terms of the foods you eat, how much sleep you get, what substances you do or do not use, how much you move your body, all of those things are really important. They are just a piece, right? So those individual behaviors, that part that you can control, is only about 25% of what determines your overall health. So I just want us to keep this in perspective, right? And realize that, well, not entirely, right? There are things that you have impact and agency and control over at the individual level, but a lot of the things that determine your health are completely outside your scope of influence, right? They are beyond you. They are things that you do not have individual control over. So I just want to make sure you realize that. So if you get cancer someday, it's probably not your fault. Okay, it has to do with all these other things too, right? It's not just about the individual behaviors that you engage in. All right, so what can we do at the public health level, at the population health level, at the community level to help improve the health of all people? So, whoops, I made a mistake there. But so when we look at ways to approach the population, the health of a population, of course, we have our healthcare system. So our doctors and nurses and hospitals and clinics. And in terms of protecting our health and promoting our health, right, they're going to help with these preventative services. So, those childhood vaccinations and ongoing vaccinations that you get as part of routine visits to your doctor, behavioral counseling. So physicians and nurse practitioners and folks do a lot with people talking about promoting healthy eating and regular sleep and regular exercise, smoking cessation, helping people to curb their alcohol use, recognize when it's a problem, all those types of things. They also do disease screening, so things like mammography for breast cancer, pap smears for cervical cancer, colonoscopies for colon cancer screening. There are lots of different conditions that we can screen for, and if we detect them early, we can prevent them or cure them. And then preventative medications. So most of you are probably not of an age yet where you need to be on any preventative medications, but as we age, if we develop certain types of health problems like high blood pressure, for example, that can increase your risk for heart disease, and taking medicine to control your blood pressure can decrease your risk for heart disease. So those are kind of preventative medications. Some of you, if you grew up drinking well water as children, you may have taken fluoride tablets, and those are preventative medications to prevent you from developing cavities. On the traditional public health side, we've got control of communicable diseases, which you're really familiar with right now, the things that we do on a population level to try to control infections, but also environmental hazards. So looking at lead in the water, looking at the health of drinking water or contaminants in the soil, air pollution, all those types of things. And then food and drug safety, right? So not only is your food safe, but are the medicines that you take safe and proven to contain what they say they do and not cause harms that are out of proportion to their benefits. And then things that we can do to reduce risk factors. So wellness programs, education programs to help people choose healthier behaviors. And then on the social policy side of things, right, there's a ton that we can do there, right? So improving the built environment, which could be anything from ventilation controls on buildings to make sure people get enough fresh air, to making sure that there are lots of parks to allow for outdoor recreation in cities. Our bike trail around Lake Monoman is an excellent example of how the built environment can help foster and promote health. Social policies are also really important for education. So for example, in the state of Wisconsin, we do not require comprehensive sex ed in our schools. That does not mean that some schools don't teach it. They do, but some schools definitely do not. And so the education that young people get on how to prevent pregnancy and sexually transmitted diseases varies widely from community to community. That's social policy, right? And then, of course, nutrition in terms of school lunch or other nutrition and supplemental programs like food stamps or the Supplemental Nutrition Assistance Program, WIC, which is Women, Infant, and Children, supplemental nutrition program for young families. And then there are things that we can do through tax codes and tax credits and incentives to help address socioeconomic disparities. So this year, the additional child tax credit that many families received actually lifted half of the children in the United States who were in poverty out of poverty. So that had a huge impact on the health and well-being of those children and those families. And then the mobility of goods and population, so making sure that trade can occur, that things can get to where they need to be. So lots of different approaches to improving the population's health, right? The health of the overall population. One of the last things that the chapter talks about is what our focus should be. And so there's kind of two different approaches, and depending on the condition, sometimes we'll use one approach or another, and sometimes we'll use a little bit of both. So on the left, we see this kind of high-risk approach. So focusing on those individuals who are at highest risk for a certain disease and condition and intervening there to kind of move them out of that high-risk category. An example of this would be needle exchange programs. So people who are IV drug users are at very high risk of getting HIV infection because it can be transmitted that way, as well as certain types of hepatitis. And those diseases can be fatal and cause lots of disability. And so targeted interventions for those high-risk individuals can include things like needle exchange programs where they can trade in their dirty needle and get a free one, free clean one, so that then they are less likely to get infected. So we don't offer that to everybody because most everybody doesn't need clean needles, right? So we're just focusing on a particular group that's at really high risk. That also happens to be what's called a harm reduction approach. Sometimes people are like, oh my gosh, then you're just encouraging them to inject drugs. And actually the data shows that it doesn't make them more or less likely to inject drugs. It just makes them less likely to get infected from using dirty needles, right? So it's a harm reduction approach. We can't fix everything, so we'll fix what we can. But anyway, we'll talk about that later probably. All right, and then the other approach is improving the average, right? Or shifting the mean, right? Trying to improve the overall, reduce the overall risk of everybody in the population by a little bit. So a good example of this would be putting fluoride in drinking water, right? So fluoride helps protect against cavities. So putting fluoride into municipal drinking water systems helps reduce the risk of cavities for everyone, right? So we're not looking for who particularly is at high risk. We're just reducing the risk for everyone. Okay. So these are all the things that we've talked about in this lecture. So all the many ways that our lives are impacted by public health, the history of public health, and some amazing things that have happened through the years that allow us to have all of these tools at our disposals nowadays to improve the health of a population. Then I talked about differing health risks depending on where you're at in the life cycle, the things that you're at risk for, and how populations change over time, both in terms of their demographics and then that nutritional transition that often happens as a country moves from being kind of less developed or having fewer resources to then becoming more developed and a wealthier nation. And then we talked about, okay, well, what are the tools that we have to impact the health of a population? So there's the healthcare piece, the public health piece, and then those social interventions piece, which is a conglomeration of laws and policies and nonprofit organizations and all types of things. We talked about the determinants of health, and instead of just using that kind of four category pie chart, now we're kind of expanding that and talking about the big gems, and then that focus on versus just looking at the high risk folks versus looking at everyone and kind of shifting the population mean. All right, I hope that was helpful, and I will look forward to seeing you next time.